I want now to talk about fetal circulation before I give you a break. When you talk of fetal circulation, we are referring to how blood flows through the fetus. We know that there are some differences between the blood flow in the fetus and blood flow in the adults. So I want to know how the blood flows through the fetus. Before I tell you how blood flows through the fetus, maybe there's some things that you need to know. You need to know that the cardiovascular system is the earliest, is the first system to fully function in the embryo. As a matter of fact, the first heartbeat is felt on the 4th week after conception. Unbelievable. Usually, day 23, you hear the first heartbeat. That heartbeat may not be functional per se in terms of pumping blood, but physiologically, something has happened. You can't believe 23 days after your conception, your heart started beating and it has never stopped. Now, why should the cardiovascular system develop this early? To enable delivery of a number of substances, either gases, for example, carbon dioxide or oxygen, nutrients the mother is eating. This food needs to reach the baby, so the nutrients need to be delivered. Hormones, there's some hormones which are within the mother. There's some hormones which are produced by the fetus. They need to be produced, to be transported. Waste products, the baby is releasing a lot of waste. We need a way in which these substances can be efficiently transported. Now, this is because the fetus is growing so fast that diffusion is not now sufficient to support the transport requirements of the fetus. There's some things which make the fetal cardiovascular system unique. This is when we compare them with the postnatal type, the type of cardiovascular system that is present after birth. One of them is that the fetal cardiovascular system lacks a functional pulmonary circulation. Well, I believe everyone understands that. The point here is that gas exchange occurs, yes, but it does not occur at the lungs of the fetus. It occurs at the placenta. And therefore, that makes also me mention this point as a second point, as with regard to the uniqueness of the fetal cardiovascular system. That there's a placental circulation that is very vital, the site of gas exchange. The other thing is also important to note. The fetal cardiovascular system will have oxygenated streams of blood and deoxygenated streams of blood, just like in the adult postnatal type. However, unlike the postnatal type where oxygenated blood is usually not allowed to mix with the deoxygenated blood unless there's a pathology, this mixing is normal in the fetal circulation. Having said so, the design of the fetal cardiovascular system is therefore in such a way that it should be able to maintain blood flow to and from the placenta. So this question goes to who now? This question goes to Rosemarion. Rosemarion, you're in?
Yes.
Okay, so Rosemary, we are saying that blood, the fetus need to maintain blood flow between the fetus and the placenta. My question to you is this: which blood vessels connect the fetus to the placenta?
Blood vessels.
Yes, which blood vessels connect the fetus to the placenta? We mentioned them sometime back in last semester.
I can't remember.
Okay, no problem. Fred, are you in?
Yes.
Okay, Fred, carry on. Which blood vessels connect the fetus to the placenta?
I also can't remember.
Okay, who can remember?
Is it the umbilical vein and artery?
Yes, they are the umbilical vessels. Right. So we have umbilical vessels which connect the fetus and the placenta. There are two umbilical arteries that take the deoxygenated blood from the fetus to the placenta. And there's one umbilical vein that carries oxygenated blood from the placenta to the fetus. All right, so those ones are present. Remember, they run within the umbilical cord. The fetal cardiovascular system is also designed in such a way that it is able to bypass the non-functional pulmonary circulation. The pulmonary circulation is not functional in the fetus. What I mean is that blood does not go to the lungs for the purpose of gas exchange in the fetus. And because blood does not go for the purpose of gas exchange, that blood that would have naturally been directed to the lungs, as the case of the postnatal time, is redirected away from the lungs because it doesn't need to go to the lungs. There's some structures which bypass or redirect blood away from the lungs. We call them the fetal shunts. We are going to see which shunts bypass the pulmonary circulation. The other unique design of the fetal cardiovascular system is this. We mentioned that the oxygenated stream of blood usually mix with the oxygenated mixes with the deoxygenated stream of blood. And that's normal. However, there's a problem. The brain of the fetus requires a lot of oxygen, really a lot. And so, in as much as the oxygenated blood usually mixes with the deoxygenated blood, the fetal cardiovascular system is designed in such a way that it's able to maintain, or it's able to redirect oxygenated stream of blood towards the rapidly developing brain, despite the fact that the oxygenated streams mix with the deoxygenated streams. We are going to see how that is achieved as well. Lastly, there's some changes because of these anatomical differences. There's some changes that we expect to occur at the time that a baby is being born. Those radical changes that occur at birth must be anticipated and handled appropriately. And the fetal cardiovascular system indeed anticipates them and handles them very well. I can't believe that was all introduction. So what do we need to learn here? We need to describe how blood flows within the fetal heart. We also need to name the fetal shunts. There are 3, by the way, and state the role of each. And we're going to see why do we need all of them. We're also going to see some of the changes that occur at birth. When a baby is born, what are some of the changes that occur that involve the cardiovascular system? And lastly, we will be having some embryonic structures which are present in the embryonic life, but they're not present in the adult life. So we're going to see what they become, or which structure do they really form. So the image here shows you fetal circulation. It might be a complex one to understand, so let me make it simple by using something we can all follow slowly. Let's assume that what we are seeing is the placenta. The placenta has some blood vessel that leaves it to go to the fetus. The blood vessel that leaves the placenta to go to the fetus is called what, Roylin? Roylin?
Hello? Pardon, please. Wait.
When unapika. All right, so Roylin, which blood vessel comes from the placenta to go to the fetus?
Artery. Umbilical artery.
Okay, we mentioned that it is the umbilical vein, not umbilical artery. So it's a single blood vessel. It is contained within the umbilical cord. It leaves the placenta and enters the fetus. Rolling back to you, at what point will the umbilical vein enter the fetus? At what point?
Then the navel.
Through the navel, great, through the umbilicus. All right, now usually after that vein has entered through the navel, it goes towards the liver. Now listen to this. Even though it goes towards the liver, it does not really empty the whole of its blood in the liver. Instead, in as much as some blood is dropped off, a big chunk of that blood goes through the liver. Okay. Tabi, are you in? Tabi? Oh, all right, Tabi. So Tabi, the blood that is coming from the placenta, how do you classify it in terms of oxygenation? Is it well oxygenated, moderately oxygenated, or poorly oxygenated? If there are those three options in the fetus. Tabi?
I would say it is well oxygenated.
And I'll agree with you as well. So this blood here is well oxygenated. This well oxygenated stream, when it goes to the liver, we are saying it doesn't empty the whole of its content into the liver. There's some blood that passed through the liver. This blood that passes through the liver passes through this structure here that we call the ductus venosus. The ductus venosus simply means the duct of the veins. That makes the ductus venosus the first fetal shunt that we are mentioning. Why do we say so? Ductus venosus shunts the hepatic circulation. The blood within the ductus venosus does not enter the circulation within the liver, which we call the hepatic circulation. That blood is shunted so that it goes through the liver without supplying the liver? Well, I mentioned that the some that will still supply the liver. And why does the liver need oxygen at this point? The liver needs oxygen because the liver is metabolically active at this point. It is producing a lot of red blood cells, and so it requires oxygen. But we still need that oxygen to also be directed to other parts of the body, like the brain needs it. That's why it doesn't empty everything into the liver. In as much as in the postnatal type, the blood that goes to the liver actually empties everything into the liver. With all that effort to ensure that this blood, well-oxygenated stream of blood, does not dilute anywhere, unfortunately, it becomes diluted because the ductus venosus empties into this vessel, which we are calling the inferior vena cava. The inferior vena cava carries blood from the lower parts of the body back to the heart. Okay, I'll give this to Tony. Tony, are you in?
Yes, I'm in.
Okay, Tony, so how would you classify the blood within the inferior vena cava at this point? Is it well oxygenated, moderately oxygenated, or poorly oxygenated?
Poorly oxygenated.
All right, Tony, what makes you think the blood in the inferior vena cava at that point is well oxygenated?
I've said it is poorly oxygenated.
Okay, that's better. I was almost getting a heart attack. All right, so it is poorly oxygenated. And the reason is clear. It's coming from the lower part of the body. So if the blood at this point is poorly oxygenated, and the one at this point is well oxygenated, it goes without saying that the one at that point is moderately oxygenated stream of blood. Okay. Adelida, we're back to you. You're in?
Yeah.
Okay, Adelida. Now this is where the blood is. It is moderately oxygenated. From there, where do you think that blood will go in the fetus? Suppose this was an adult, where will that blood go? Adelida, kwani umelala ama bado unasafu?
Sijui.
Okay. Geraldine?
I think it will go to the heart.
Very good. It will go to the heart. We know that blood in the vena cava go to the heart. Geraldine, which chamber of the heart?
The right one, the right chamber.
Which right chamber?
The right atrium.
Very good. That blood enters the right atrium. Now, I want you people to see here. This is the right atrium receiving blood from the lower part of the body through the inferior vena cava, as well as the upper part of the body through the superior vena cava. Okay, Florence has just entered, so let me skip her and ask Fred. Fred, you're in?
Yes.
Okay, Fred, blood from the superior vena cava, how do you classify it in terms of oxygenation? You're keeping in mind the terms we've been using.
Poorly oxygenated.
Poorly oxygenated, very good. And if it was possible to say very poorly, I would have still said so. So it is poorly oxygenated stream because this blood is coming from the upper part of the body. One important organ in the upper part of the body is the brain, which utilizes a lot of oxygen. And so that blood is really, really low in oxygen concentration. Now see another unfortunate thing happening. This stream is moderately oxygenated. This stream is poorly oxygenated, and they're all mixing in the right atrium. Bad news. However, there's a good news. The good news is that even though those two streams of blood both enter the right atrium and that there is some contact, the two streams of blood do not necessarily mix or do not significantly mix. That's the good news. Why do we say so? There are two exits from the right atrium. One is towards the right ventricle through the atrioventricular valve, and the other one is to the left atrium through this opening, which I'm going to give you its name shortly. Or let me just give you the name. We call it foramen ovale. So blood from the right atrium can go to the right ventricle. Blood from the right atrium can go to the left ventricle. Sorry, can go to the left atrium. Let me say that again, I got distracted. Blood from the right atrium can go to the right ventricle through the atrioventricular valve, but blood from the right atrium can also go to the left atrium through the foramen ovale. So the big question is, which blood vessel will enter where? Which blood stream will go via which route? That's a big question. Florence, what do you think? The stream from the superior vena cava, where is it likely to go? Is it likely to go down or likely to go left? Florence, carry on. Florence, are you in class? Okay, carry on, yes.
It's likely to go down.
Okay, what makes you think it will go down?
I don't know.
Okay. So blood from up, yes, goes down. And the reason it goes down is because of, if you think through what we call streamline flow. That means that the blood from the down here will use that direction and pass through the foramen ovale. So blood from the superior vena cava, because of streamline flow, direct down through the atrioventricular valve to the right ventricle. Blood from the inferior vena cava, again through streamline flow, will be largely directed through the foramen ovale to the left atrium, as you can see here. So the concept here is that the two streams of blood are following a streamline flow. Great. Let's follow these two streams. Remember, the stream from the superior vena cava is poorly oxygenated. That stream is directed to the right ventricle through the atrioventricular valve. The stream from this inferior vena cava is moderately oxygenated. That stream is directed to the left atrium through the foramen ovale. Let's follow one of the streams. We can start with the stream from the inferior vena cava. So the stream from the inferior vena cava goes through foramen ovale and enter the left atrium. Johnny, are you in?
Yes.
Johnny, from the left atrium, where do you think this blood will go?
To the left ventricle.
Very good. It will go to the left ventricle. Now, you people, I hope you've noticed something. That blood in the left atrium, oxygenated blood, has gone, sorry, blood in the right atrium, which is well oxygenated or moderately oxygenated, has gone to the left atrium directly through the foramen ovale. That means what? That the foramen ovale is a shunt. Foramen ovale is the second fetal shunt we mentioned. Remember, the first fetal shunt we mentioned was ductus venosus. And we said it shunts blood from the umbilical vein to the inferior vena cava, therefore bypassing the hepatic circulation. This is the second fetal shunt we're mentioning. And we're saying it takes blood from the right atrium to the left atrium. Joy, are you in?
Yes.
All right, Joy. So now that the foramen ovale takes blood from the right atrium to the left atrium, which circulation does the foramen ovale bypass? Any idea? Kenya?
Pardon?
Which circulation does the foramen ovale bypass?
Excuse me, sir, I was distracted. Could you please pardon?
Okay. So foramen ovale bypasses the pulmonary circulation. That is why blood from the right atrium goes direct to the left atrium. So it skips the pulmonary circulation. Why do we say so? Because we know that the right chambers of the heart usually take blood to the lungs. Then from the lungs, they go to the left chambers. Now we are coming from the right chambers to the left chambers directly. So foramen ovale bypasses the pulmonary circulation. We are going to see another one, and you'll tell me which circulation it will be bypassing. Okay, so from the foramen ovale, it has gone to the left atrium, then it goes to the left ventricle via this valve. That is what we call the bicuspid valve, or the left atrioventricular valve. From the left ventricle, the blood goes to the aorta through the aortic valve. It will go to the aorta through the aortic valve. Now, which part of the aorta will it go to first? It will go to the ascending aorta, which is this one. Remember, this stream is moderately oxygenated. So it goes to the ascending aorta. Meanwhile, in the process, oxygenated blood goes to the coronary arteries. So the coronary arteries receive oxygenated blood, and it makes sense. We need oxygen for the heart. The heart is pumping actively, so it requires oxygen. And so that's good news that we are able to make the heart receive oxygenated blood. From the ascending aorta, it will go to the arc of the aorta. And when that blood goes to the arc of the aorta, it means it will go to the branches of the arc of the aorta. Mariam, are you in?
Yes.
Okay, Mariam, what do you call this vessel?
So my internet's a bit slow, so I can't see the cursor moving.
Okay, the first branch of the arc of the aorta, what do you call it? The first branch of the arc of the aorta. The one to your left-hand side, yes.
To the left, I think
Yes,
that's
the most
the
left vessel from the arc of the aorta, what do you call it?
subclavian.
No, that will be the brachiocephalic trunk.
Oh, right.
The one to your left-hand side, which is on the right side of the patient. This is the brachiocephalic trunk, which gives you right subclavian artery and right common carotid artery. Back to you, Mariam. The second vessel from the arc of the aorta, what do we call it?
The common carotid.
Good. So that's the left common carotid, and the third one will then be called the left subclavian. Thank you, Mariam. Despite your internet challenge, you've done well. So these three are branches from the arc of the aorta. Mercy, you're in?
Yes.
Okay, Mercy, tell me one common organ that all those three arteries supply. One common organ. Mercy?
The lungs.
Why do you say so? Mercy, do you really want blood in the common carotid and subclavian arteries to go to the lungs, and you still want to be alive? We agree that the lungs receive pulmonary arteries and bronchial arteries, okay? Fares,
Yes.
any idea? Fares? Okay. The common organ that those three arteries supply is the brain. Okay, Fares, I think your internet is troublesome. I'll excuse you. Rosemary,
Yes.
remind us the two systems of arteries which supply the brain and tell us where they come from.
Pardon, I've not understand the question.
Remind us the two systems of arteries which supply the brain.
The brain. What?
Any idea?
The carotid arteries.
So, which carotid arteries supply the brain, Rosemary?
Mm, the internal carotid arteries.
Okay, so what's the other system of arteries that supply the brain apart from the internal carotid system?
Can you say the cerebral?
Not exactly. We mentioned that the brain receives two systems of arteries, the internal carotid system, which is responsible for what we call the anterior circulation, and the vertebrobasilar system, which is responsible for what we call the posterior circulation. Those two arteries anastomose at the base of the brain on what we call the arterial circle of Willis. Then from this arterial circle of Willis, there are arteries which now go to the cerebral cortex. Those are the ones we call anterior, middle, and posterior cerebral arteries. Now I'm just asking you where the two systems of arteries come from. The internal carotid system comes from the common carotid artery, which are these ones. The vertebrobasilar system comes from the subclavian arteries, which are these two. So it is okay for us to conclude that these three arteries supply the brain. Now, what I want you people to notice, therefore, is that apart from the heart, oxygenated blood is also directed to the brain through that channel that we've described so far. Of course, not everything will go to the branches of the arc of the aorta. Some blood will still go down to the descending aorta. We can put a comma there, then follow the other route. Remember, we were in the right atrium and there were two options. One to the left atrium and one to the right ventricle. We followed the route to the left atrium. Now let's follow the route to the right ventricle. So from the superior vena cava, we have poorly oxygenated stream of blood which enters the right atrium, then goes through this valve to the right ventricle. Okay, this one goes to Roylin. You're in?
Yes, I'm in.
Roylin, give us the name of this valve.
Tricuspid valve.
The tricuspid valve. Good. So that's what we call the tricuspid valve. So blood from the right atrium goes to the right ventricle through the tricuspid valve. Blood from the right ventricle goes through the pulmonary valve to this channel here, which we had called the pulmonary trunk. From the pulmonary trunk, listen to this, blood does not go to the pulmonary arteries as would have expected it to do in the postnatal type. Instead, blood from the pulmonary trunk goes to the descending aorta through this channel here, which we call the ductus arteriosus. So ductus arteriosus is the third fetal shunt we are mentioning. Ductus arteriosus takes blood from the pulmonary trunk to the descending aorta. Tabby, you're in?
Yes.
Okay, Tabby. Mamejibu na psych. That's good. So Tabby, blood from the pulmonary trunk enters the descending aorta through the ductus arteriosus, which means that ductus arteriosus is a shunt. My question to you is this: which circulation does the ductus arteriosus shunt?
At which circulation?
Which circulation does the ductus arteriosus bypass?
The systemic.
What makes you think it is systemic circulation?
I'm not even sure.
Okay, I'll give it to Tony. Tony, are you in?
Yes, I'm in.
Okay, can you try that?
I think it is still pulmonary circulation.
It is still the pulmonary circulation. Thank you, Tony. Because blood in the pulmonary trunk usually goes to the pulmonary arteries, which will take blood to the lungs. But in this case, blood in the pulmonary trunk goes direct to the descending aorta through the ductus arteriosus. So the ductus arteriosus, just like the foramen ovale, also bypasses the pulmonary circulation. Now I have a difficult question. I'll open it up to anyone who wants to answer. We have seen that there are two shunts which bypass the pulmonary circulation. The ductus arteriosus and the foramen ovale. My question to you is, why do we need two shunts to bypass the pulmonary circulation? Why not just one? Anyone?
Can I try?
Yes, Tony.
I think because usually the blood passes the heart twice.
So what if the blood usually passes the heart twice? Okay, there is a, yes, Geraldine, you can try.
Can you say it is trying as much not to reduce the concentration of oxygen within the blood?
That's true. For what purpose? Because look, eventually the blood that is through the ductus arteriosus still enters the descending aorta, and so they're still mixing. This blood, which was moderately oxygenated, still mixes with the blood that is poorly oxygenated into the descending aorta eventually. So why was it trying not to mix them initially?
Is it so that most of the oxygenated blood is supplied to the brain?
That's very good. Thank you. If there was a way I could clap, I would have clapped for you. I'm impressed. So it is to ensure that the oxygenated stream is redirected to the brain first. It is also redirected to the heart first. So that oxygenated stream goes to the heart, then goes to the brain. Then now we can afford mixing with the deoxygenated stream. As you can see, the ductus arteriosus is located distal to the branches of the arc of the aorta. Great. So from there, whether the stream was the foramen ovale stream or the ductus arteriosus stream, the two streams have now mixed. Remember, foramen ovale shunts moderately oxygenated stream from right atrium to left atrium. Ductus arteriosus shunts poorly oxygenated stream from pulmonary trunk to the descending aorta. Whether it was from which stream, we're now in the descending aorta. And from the descending aorta, the journey is straightforward. From the descending aorta, blood goes like that all the way, abdominal aorta, then divides into two, the right and the left common iliac arteries. So the blood will still follow those two. The common iliac arteries also divide into external iliac and internal iliac arteries. If you want to go to the placenta, then the blood follows the internal iliac artery. So the blood that is following the internal iliac artery is the one that will be headed to the placenta. The reason is because the internal iliac artery is the one that gives you the umbilical arteries, right and left umbilical arteries, which then go through the umbilicus again and join the umbilical cord within there to the placenta. All right, ladies and gentlemen, we started at the placenta and we've now ended at the placenta. So that is the fetal circulation. Right, I know I have used some of your neurons a lot. I'll give you a break. So it is now what time? It is now 17 minutes past 5. Sorry, past 3. Sorry, I think I'm sleepy. So take 8 minutes. Let's come back at 25 minutes past 3. I believe you've rested enough. Sorry, I got occupied kidogo as well. So we are now going to look at the circulatory changes which occur when a baby is born. There are a number of changes that will take place at birth, that point when a baby is born. There are a number of changes which will take place in the cardiovascular system. These are the ones we are calling circulatory changes at birth. So obviously, one of the changes is that we will no longer have the placental circulation. The placental circulation will cease to exist the moment a baby is born. But importantly, is that the pulmonary circulation will now open up so that gas exchange can now occur through the lungs. So that's an important change as well. Now let's think through that. When the pulmonary circulation opens up, so blood goes to the lungs, that means that a lot of blood then enter the left atrium from the lungs. That aspect makes the pressures in the left chambers of the heart to rise higher than the pressures in the right chambers of the heart. And so we can consider that as another change. You know, initially, the right chamber pressures are usually higher than the left chamber pressures before birth. Because of many things, the pulmonary circulation is not open, so the right chambers are just pumping to something that's not open. The pressures on the right chambers are high. And the blood that goes to the left chambers wholly come from the right chambers through the foramen ovale. So definitely, the right chamber pressures must be higher than the left chamber pressures. But now at this point, the pulmonary circulation has opened up, blood goes to the lungs, so that reduces the pressures in the right chambers. Then a lot of blood then enters the left chambers, which means that the left chambers now increase their pressure. So the left chamber pressures become higher than the right chamber pressures. The change in the chamber pressures cause the foramen ovale to close. So that's another change, that the foramen ovale closes. Let's see how the foramen ovale actually closes. Let's consider this to be the fetal heart. Right atrium and left atrium there. So this one here is what we have prenatally. There are usually two septum that separate the right and the left atrium. This thin one, which seems to appear to be from below, is the first septum to form. We call it the primary septum. In Latin, it's known as septum primum. And then this thick one, which appears to come from the roof, is called secondary septum, or in Latin, we call it septum secundum. So we have septum primum and septum secundum. These two septum are the ones that separate the right and the left atrium. As we can see, there is a gap between the two, which we call the foramen ovale. So prenatally, the right chamber pressures are higher than the left chamber pressures, and that enables blood to flow from the right to the left atrium through the foramen ovale. Therefore, foramen ovale remains patent prenatally However, after birth, the left chamber pressures become higher than the right chamber pressures. So what happens? If the left chamber pressures are higher, they'll push the primary septum backwards like that. And so that means that the primary septum makes contact with the secondary septum, therefore closing the foramen ovale. We call that physiological closure of the foramen ovale. The physiological closure of the foramen ovale involves just the flapping of the primary septum to the secondary septum. And this occurs because of pressure difference between the right and the left chambers. It occurs at birth. Because it's just a matter of pressure difference, it means that by any chance, if the pressure in the right atrium ever goes up, the foramen ovale can actually open up again. And that sometimes happens when a baby cries so much with a lot of strain. The foramen ovale can open because now when they strain, the pressures in the pulmonary system become high, and so the right chamber pressures become high at a moment. During that moment, where the right chamber pressures are higher than left chamber pressures, indeed, the foramen ovale can actually open, although it's just a moment. So it's not something to worry much about, although it is worth noting that, therefore, a baby can actually cry until they turn bluish. And next time we're meeting, you'll tell me why they turn bluish. Right. Ignore about the bluish now, and let's talk about physiological aspects of it. So the left chamber pressures have become higher. The primary septum flapped back to the secondary septum. Foramen ovale has closed. We call that physiological closure of the foramen ovale. Later on, the primary septum and the secondary septum fuse pole-pole over a period of time. Give it 12 months. The primary and the secondary septum fuse permanently. And that permanent fusion of the primary and the secondary septum is what we call the anatomical closure of the foramen ovale. The anatomical closure of the foramen ovale occurs within the first 12 months after birth, after which now it is not possible to reopen the foramen ovale. Now, look at this. When you look at this region where the foramen ovale was, if you put your eye in the right atrium, you'll see a depression. That depression is known as the fossa ovalis. And this is it. This is the right atrium, the chamber. This is the fossa ovalis. So the fossa ovalis represent the fetal location of the foramen ovale. It is something present within the right atrium. Okay, let's talk about another change that occurs. At the time of birth, we also have closure of the ductus arteriosus. Just like foramen ovale, ductus arteriosus also closes in style. We have physiologic and anatomical closure of the ductus arteriosus. The physiological closure of the ductus arteriosus involves vasoconstriction. You know, ductus arteriosus is just a blood vessel with the tunica media that contain vascular smooth muscle. So the vascular smooth muscle of the ductus arteriosus contract in that process of vasoconstriction, and so narrowing and obliterating the lumen of the ductus arteriosus. That occurs within the first 3 to 7 days after birth. That is physiological closure of the of the ductus arteriosus. Later on, maybe around 2 to 3 months, the walls of the ductus arteriosus fuse permanently. And that is what we call the anatomical closure of the ductus arteriosus. When the walls fuse and so the lumen is permanently obliterated. When the ductus arteriosus closes anatomically, the structure that remains connecting the two becomes a ligament. And that ligament is known as the ligamentum arteriosus. You and I do not have ductus arteriosus, hopefully. We have the ligamentum arteriosus. Another change is that, when a baby is born, the midwife will actually tie the umbilical cord. When you tie the umbilical cord, the umbilical arteries will close. They'll close because you tie the cord. With time, the umbilical arteries become ligaments, and these ligaments are known as the medial umbilical ligaments. So again, you and I don't have the umbilical arteries. We have the medial umbilical ligaments. These ligaments are seen on the inside of your abdominal wall, not outside, extending from the region of the umbilicus all the way to the pelvis, where they were arising from the internal iliac arteries. So we have the medial umbilical ligaments, we don't have the umbilical arteries. The umbilical vein will also collapse and close. If the umbilical vein collapses and closes, that means that even the ductus venosus will also close. What do they become? Remember, the umbilical vein was coming from the umbilicus, the navel, to the liver. It becomes a ligament. That ligament is known as the ligamentum teres of the liver. So you and I have the ligamentum teres of the liver, which extends from our anterior abdominal wall internally to the liver. We call the ligamentum teres of the liver. Within the liver, where the ductus venosus was found, we now don't have the ductus venosus. We have a ligament there, and that ligament is known as the ligamentum venosus of the liver. Right, so these are the changes that occur in the circulatory system at birth. I think I'll need to be fair to you and to myself. Now we'll not be able to do the congenital heart defects because this will take us another 1 to 1.5 hours. So we can postpone this one. Therefore, I'll stop there and